I'll give you, I'll give you a little bit of background and then would love to hear your thoughts and the audience thoughts as to like how to reconcile some stuff that I was unable to. But this is a guy who's in his late 50s. He has chronic kidney disease of unclear etiology. And unfortunately, he recently had a sort of respiratory event due to tracheal malacia and had to be intubated and then eventually had to have a trach and subsequently actually got a peg tube as well. This is like maybe a year or two ago. So he's at a assisted living facility and they're checking his labs daily. And you know, Madalena, I don't think you need to share the screen. There isn't gonna be too much data, but thank you for asking. Without that caffeine, you're on top of it. So because okay, so then they're checking daily labs and his like normal creatinine is 1.6. He's not cachectic by any means, but he is pretty sedentary and isn't as active. So the last, like the whole month of August, it was 1.6. Then in September, it like rose steadily to 2.0 and has stayed stable at 2.0. But now what we're seeing is sort of a consistent rise in his BUN. So the creatinine stabilized at 2.0, but the BUN went from like 50 in August. Then it was around 60 to 70 when the creatinine was 2. Now it's 94. In this context, the nephrologist recommended admission for accelerated workup for acute on chronic kidney disease. And then just one other piece of information from his past medical history. He does have some form of cancer and is on pembrolizumab monotherapy for that cancer. And so this was the context. And then when I see him, his potassium has actually been like 3. So hypokalemic. His bicarb has been 32. His pH is 7.39 and his PCO2 is around 60. So I have this hypokalemia. I have what looks like a chronic respiratory acidosis with metabolic compensation, maybe a little more, and worsening renal function, or at least a discordance between BUN and creatinine. I'm going to pause there because this is all the data we had. And then it was time to put the pieces together and see what we can do for this individual. And I will tell you, if you read my attestation, and there's a funny story, a funny twist about all of this.
I can't wait to reflect and nerd out, but I'm curious what the folks think. Thanks for, this is a really intriguing case. Slowly progressive kidney dysfunction, cancer, immunotherapy. What do y'all think? I know David is scratching his beard, thinking really hard. What are you thinking, buddy? What crossed your mind? Yes. The BUN has been rising without creatinine and potassium. Is that right, Prof. Rez? Like the BUN is rising disproportionately? Amazing. Yeah, what does that make you think of? You can unmute. Go ahead and unmute. Right, Prof. Rez doesn't bite, I promise. He has the Invisalign.
I already had my breakfast this morning, so I'm not hungry.
Hans, what are you thinking typing away?
I was thinking maybe all of a sudden there's a breakdown in proteins in his system. Maybe the metabolism increased somehow. And he was, but this should have happened much earlier because he was immobile for a long time. So usually we have a breakdown of muscle mass, but this does not apply here. It's just an increase in BUN. So nitrogen has to come from somewhere. If his nutritional status or intake has been the same all the time, something must be breaking down in the body. This was my thought.
Love it. That's such a wise thought, Hans. Whenever you're seeing that BUN, it's almost like your schema is increased production or reduced clearance, and I think both may be at play for sure. Deborah, what are you thinking?
Actually, I was trying to follow everything that Professor was talking. What I got was hypokalemia, respiratory chronic acidosis. And now I saw the chat that the boom was rising. I don't know. I think like I was thinking that creatinine, it's in the, like when the thing that I was trying to think about, when we do hemodialysis, the boom get lower, like we see a really difference in the boom because it's with outside the cell, and the creatinine, it's inside. So I was thinking maybe something like that, but I don't know. I don't know if that has anything to do with that.
I mean, I think
But-
that, yeah. I think that's where my head is going too. I think it's the source. It seems like the lesion that people are thinking about is what is the source of this disconnect between the BUN and the creatinine? I think that's very, very wise. Maddie, what did you think?
Yeah, so I'm trying to think which one I should be focusing my energy on. So we have, you know, the hypokalemia, we have this kind of acute on chronic kidney disease, then the chronic respiratory acidosis. So I'm trying to figure out which one I should be maybe focusing on here. You know, the hypokalemia stood out to me as 3. And so I was initially thinking, you know, initial branch point you can think of, like, did it go out through the GI tract or the kidneys, or did it go into cells? And maybe with the acute on chronic kidney disease, it's not going out through the kidneys. So is it going into cells or out through the GI tract? So that's kind of where my thinking was at this point. But I'm not entirely sure.
Yeah, no, maybe what we can do, Prof. Raz, is I can also share with you a mini case and that you can facilitate the magic of this audience. And I'll share my thoughts now for yours, just to be able to get a couple of cases in. I think that this case is like a paradox, right? There's so many things. The BUN is rising out of proportion to the creatinine. The potassium, as Maddie just highlighted, is unexpectedly low in patients with kidney disease. You expect the potassium to rise when the kidney dysfunction gets worse. And so I think when paradoxes happen, when you're like scratching your chin and you're like, why are things going the opposite way? It's either because the case is confusing and won't make sense, and you're like, oh, you know what, I'm just going to dismiss some things and just make it more simple. And medicine is complicated, so things can be unexpectedly complicated. But sometimes when there's a paradox, it filters you into a more unique circumstance. And I think the unique circumstance here is the combination of AKI plus hypokalemia, right? Even, let's put the B1 aside for a second, say, okay, the creatinine has been rising, period, and the potassium has been dropping. That's weird. And what does that do? I think the most common scenario that means is that the patient is usually having diarrhea or GI loss and causes hypokalemia, and the GI losses cause AKI. So let's hold that thought. Like, is there GI losses? And the other scenario that happens is best illustrated by when we over-diurese people. When you over-diurese people with Lasix, you give them hypokalemia and AKI. And there's nothing special about Lasix. It's any tubulointerstitial disease. You can poison that exact channel by medications, or you can leave that channel dysfunctional by having an interstitial disease in that space. So the combination of AKI plus hypokalemia is usually a GI issue, but can be an interstitial issue. And that's the localization, really. I can't think of anything else that does that. And so the question is, as we hold these two thoughts together, GI losses and interstitial issue, is there anything that puts the patient at risk for these conditions? And the answer is heck yes. And that's where I think you get momentum in this case. You get momentum by saying pembrolizumab is a culprit and notoriously causes interstitial nephritis. So that's a connection. But then the other, oh, they also is on Lasix. Nice. All right. The other connection maybe, which is probably more concerning, goes back to bringing in and reincorporating the BUN. So when you go back and you're like, my two possibilities were GI losses and interstitial issues, I know pembrolizumab does GI, does interstitial, does it do GI? And yes, pembrolizumab induced colitis is very morbid and severe and often refractory to treatment. And so how does that loop into BUN? Could this patient have colitis, have occult upper GI bleeding? And that's why the BUN is disproportionately elevated compared to the creatinine. That's a phenomenon that is well described in patients who have an upper gastrointestinal bleed as a result of what Hans, Deborah, and Maddie were emphasizing. There's an increased protein load, which delivers increased nitrogen to the liver, which causes increase in BUN. So I think it's hard to know what's going on, but I would query the patient about any GI symptoms, nausea, vomiting, diarrhea. But I think the worry in this patient would be, is pembrolizumab the cause here? Well, either mechanism. And I cannot wait to learn what Prof. Rez's attestation is. They're usually like NAGM CPS style answers, just so all of you have some context. So enlighten us, Prof. Rez.
Well, first of all, that brilliant discussion, folks. That was incredible. And it's like really interesting when you do identify these paradoxes or things that don't make sense. They're often a clue to something, underlying. And like, for example, someone with heart failure and weight loss, like that's a paradox in most circumstances. And Robbie, the way we approach this BUN creatinine discordance, we did think about increased protein load. I loved your framework of, is there more protein, Hans, or is there decreased clearance? And this patient is on tube feeds. And we thought, could he have had his tube feeds change where they increased the protein, the amino acids that led to a higher rise in BUN than the creatinine? And the truth is, no, there wasn't any change in his tube feeds. We thought about the, endogenous sources of protein like bleeding, but his hemoglobin has been stable. His stool has been normal in color. And then I remember when I was a resident, I learned that patients who are cachectic, like they don't have much muscle mass, because remember, BUN is different than creatinine. Although we report those two together, their origin is totally different. Creatinine is coming from the muscle, right? While BUN is coming from the breakdown of amino acids and the urea cycle. So although his weight has sort of slightly declined, he is pretty immobile. And if you're not exerting the muscle mass, you can have a redistribution of body weight. So one of our thoughts was, could it be that he's just exhausted his like creatinine stores and it's not an accurate reflection of his eGFR, but his BUN is rising because his eGFR is low, but the creatinine can't estimate it because he's losing muscle mass. And so to test this hypothesis, we sent a cystatin C. Let me pause there for a second, Rob, because I think it's like a very rich case. I just want your reflection, facilitate whatever you want based on what was said.
I think that's amazing. There was a recent, last week's JAMA clinical case was just highlighting what you just said. And I think a lesion in my thinking was assuming that the creatinine remained an accurate estimate of GFR. And I think now a clue to use going forward is when the BUN is rising and the creatinine isn't, ask yourself, is that because the creatinine has lost its ability to predict the GFR? I think that's superb and not something that I thought of. So it's almost like a falsely elevated BUN to creatinine ratio, maybe because the creatinine isn't rising when it should. Check a cystatin C. That's a really, really good pearl.
So then Madalena, I think, highlighted a really great approach to hypokalemia in the context of renal insufficiency, because you would expect the potassium to rise when someone has worsened kidney function. And in general, when you're approaching hypokalemia, you can basically, you never really have to send urine potassium. Like you really don't. Like history alone should be enough to get to the history, and a few other labs should be enough to get to the diagnosis of hypokalemia. But if you are going to send urine potassium, spot urine potassium is helpful. And we did send it in this patient, and we were already anticipating that it wasn't renal losses of potassium just based on the worsening renal function, unless it was Lasix, Robbie, as you mentioned. But the spot urine potassium was very low, like 10. So it's telling us that there's probably extrarenal causes of potassium loss. And for that, we focus on the GI tract and the transcellular shifts. For the GI tract, no vomiting, no NG tube, no diarrhea. Like everything is normal. Like actually the patient doesn't even know why he was admitted to the hospital. He's like, I feel totally fine. Nothing has changed. And his tube feeds haven't changed. So then we started thinking transcellular. He does have history of COPD, but he's not really using his albuterol that frequently. He doesn't have diabetes, so he's not being administered insulin. So to be honest, I'm still not sure why this K, and I just checked his labs today and the K again is 3.0. Like I have no idea why this patient has hypokalemia. But back to the, actually, let me pause there and then I'll talk about the, Robbie, thoughts on the hypokalemia, if you can.
Yeah, no, I don't know. It's tricky. Yeah, I don't think I have any. I think yeah, some people just need potassium replacement when they take Lasix. I think that's a hypothesis to entertain, but that meets a wall when you say that the spot potassium, urine spot potassium is not high. And the question is, when was that checked? Because the effects of Lasix may have worn off when the spot urine potassium has come back. And I remember that Uncle Bob asked us to install that caveat in our schema about when diuretics are used. And so you'll see the schema, there's like a the urine electrolytes may be normal between doses of Lasix. So that's one hypothesis. But short of that, I don't know. And I'm also wondering, like, what the cystatin C was, and if we're framing this case as progressive kidney disease, are those both questions still open? Why is the potassium low, and why is the kidney function progressing? Because if those are still happening simultaneously, then I would wonder, wait, does this patient have tubulointerstitial disease? But if the cystatin C is not elevated, then I'm stuck again.
No, but you know, I love that point, because like when we practice medicine, we got to do what's common, and probably most common is that the Lasix caused the hypo-K. Then we check the urine potassium a bit delayed from like holding his Lasix, and now the urine potassium is like, if you're a betting person, that's probably likely. Now, if it stays persistently low, and then you maybe have to reevaluate and reinvest some cognitive energy. There was one other interesting hypothesis here, was that before we get into the worsening kidney function, was we saw the hypokalemia, and then we saw a bicarb of 32. I'm not sure what the bicarbs are in your records, but in our system, 24 is normal, 32 is elevated. And whenever you, actually, I think this is a great teaching point, Robbie, maybe you can facilitate this. When you have an elevated bicarb, can you make any conclusion, or how do you actually evaluate an elevated bicarb in your practice?
Yeah, what do y'all think? So all you know is the patient has an elevated bicarb. What crosses your mind? Like, how do you begin to break that down? Beautiful, huh? Do you want to say that out loud so folks on YouTube can hear it?
The first thought was hypoventilation. So he is in ICU or very much immobile. So maybe his muscles of breathing are getting weak.
Yeah, 100%. I think that's a very good thought. Very good thought. Camilla, David, Deborah, Maddie, thoughts? It's tricky. I think the core question is the bicarb the problem, or is it protecting you against something? And the way to determine that is to get the pH. If the pH in a patient with a high bicarb, if the pH is also high, then you're like, wait, the bicarb is causing a problem. If the pH is low, then you're like, oh, wait, no, the bicarb is protecting the patient from even worse acidosis, right? So when Prof. Rez gave us the pH of 7.39, it's a little bit tricky because the pH is normal. So what do you do then? And I think that, if the pH is normal in a patient with elevated bicarb, their CO2 must also be elevated, right? So in that situation, you were trying to figure out, well, which one started it? Did the PCO2 rise and the bicarb follow? Or did the bicarb rise and the PCO2 follow? And so I think there you have to go back to Well, what elevated bicarb is usually a kidney issue, either direct or indirect. And this elevated CO2 is a lung problem, either direct or indirect. And let me clarify, a lung problem inherently may be a lung problem, or it may be a neurological issue causing hypoventilation. A kidney problem from bicarb could be an inherent kidney problem or reduced kidney perfusion from GI losses. So the kidneys bring in the GI tract and the lungs bring in the nervous system. And so the question you're trying to see is, I can't figure it out from just the foreground data. So what's this patient at risk for? And the patient has progressive kidney dysfunction. So could the kidney be at play? And so the way I would solve this is say, does the patient have any lung or neuro issues? And we heard that he has lung cancer. And so could he have smoking, COPD? So long story short, my head's spinning and I don't know where to go because everything is possible. And I think practically, if you, again, just like Prof. Rez said, hold the Lasix, what happens to the potassium? Lasix causing a contraction alkalosis is a very plausible hypothesis. So while I sit here and think and map it out and draw it, practically stop Lasix, maybe give a little fluids and see what happens to the bicarb is one way you could try to remove yourself from the chaotic mess that I just created for you. Prof. Rez, enlighten us, please.
That is exactly right. And I love David's comments about aldosterone and lung cancer. Like, I love that. That's really, really clever. And so the way we interpreted this acid-base disorder, like Hans was saying, is that the patient has some degree of hypoventilation or COPD or obstruction, because you see the PCO2 is 56. Normal PCO2 is 40. So we know this patient has like a chronic respiratory acidosis. And the rule is for every 10 that the PCO2 rises, you expect the bicarb to rise by 3 to 5 for a chronic respiratory acidosis. So for this patient who's, let's say the PCO2 is 60, so that's 20 above 40, right? So that's 10 times 2, Robbie, equals 20. So that's two sets of 10. So then 2 times 3 is 6, or 2 times 5 is 10. So we would expect this bicarb to be between 6 and 10, above the normal bicarb of 24. And so this bicarb should be between 30 and 35 if this is just appropriate compensation from the kidneys. Now, why this becomes a bit complicated is the kidneys are also involved in maintaining acid-base homeostasis. And we know this patient has poor kidneys. So could it be that this patient's bicarb would actually, this bicarb of 34 is not accounting for the bicarb decrease from the chronic kidney disease? You see what I'm saying? Like if the kidney was acting totally normal and there was no kidney disease, this is exactly what you would expect the acid-base disorder to be for chronic respiratory acidosis, right? But we know the kidney's not functioning well. We know that this eGFR is like 30. So this bicarb is like teasing you. It's saying that it's high. Do you guys agree, or is it too early in the morning? Robbie, can you restate that?
Yeah, 100%. It's a very complicated topic, but it's all about what you expect it to be in a certain circumstance. You expect the bicarb, if the story begins with this patient has obesity hypoventilation, their CO2 rises, their bicarb rises a certain level, and their bicarb is exactly what it should be. Boom, done. But the patient has kidney disease. What does kidney disease do to the bicarb? It lowers it, right? So if the story is true that the CO2 caused the rise in bicarb by renal compensation, done. But here we have kidney issues. So the bicarb should be lower because of the kidney issues. And the fact that it's not lower leaves some elevation in bicarb unaccounted for and unaddressed. Is that fair?
That's beautiful. Does anyone have any questions about that? Because now it's going to get really interesting. So then
now it's going to get really interesting. Oh my gosh.
This is where it gets interesting. So, and I'm going to throw this question back to you, Robbie. You have, let's say, a metabolic alkalosis now, right? A concomitant. So you have chronic respiratory acidosis. You have some compensation, but more than you would expect. And that's why you're probably getting to a pH of 7.4. So there has to be, in my opinion, a concomitant metabolic alkalosis, which is rare in the context of CKD, which is rare. This patient is not on any kind of calcium carbonate or Tums or anything like that. So one theory is actually probably the most plausible theory, which I didn't even think about when I was in my NEJM attestation mode, is Lasix. Okay, hypokalemia, kidney injury, metabolic alkalosis. But I'm curious, and David, I think hit the nail on the head. This pattern prompted me to activate inappropriate aldosteronism. Right, inappropriate aldosteronism, and that's when we're like sort of working up metabolic alkalosis. And I sent a urine chloride, but the urine chloride came back really low. So let me pause there and pass the mic back to Robbie to clean up this mess.
I don't know. I think there is no mess here. It's all very intriguing. So if you just, I think understanding alkalosis is actually can be pretty complicated, but comes down to one simple thing, which is if you just stick to the premise that bicarb and chloride exist in a balance. What alkalosis is a perturbance in that balance, that there's chloride loss and bicarb gain. So it just kind of shifts. So the real question you're asking when you have alkalosis is, why did I lose all this chloride? And you see, when you measure the kidney issues, when you look at the kidneys, you see that, wait, the kidneys aren't losing this chloride, that they're being lost somewhere else. And so you then ask yourself, well, where do I lose chloride? And the most common places you lose chloride are in the upper GI tract when you vomit HCl or acid. That can happen also with an NG tube too. You can also lose chloride in the skin through sweating, but that's exceedingly rare. Okay. So you're like, wait, hold on. The patient has no GI symptoms, has no evidence of skin loss. Why are they losing their chloride? And then you realize, wait, hold on. This patient is on Lasix. And could they have lost chloride when you gave them the dose? And now they're trying to hold on to all the chloride that's left between doses. So I'll just show you visually. It's tricky without a picture, so let me pull it up real quick. Almost there. All right, ready. So I think, as David said, and as Reza sneakily taught us, metabolic alkalosis, you just have to make sure the patient isn't taking anything that has a bicarb. And the question, if that's not the case, then all of it is mediated by aldosterone. Aldosterone is the molecule that does the switch between bicarb and chloride. And so is it because there is chloride loss and aldosterone is trying to compensate for that? Or is aldosterone is going crazy for no good reason doing this thing? And the way you tease that out is using a urine chloride. And when the urine chloride is low, you know that aldosterone is acting appropriately. It's supposed to do this. And so we're back to, is there GI losses or the skin losses or the renal losses? And there's nothing to suggest this. There's nothing to suggest this, but there's kidney dysfunction. So for me, I'd be like, oh, wow, let's give this patient fluid, fix the Lasix issue and see what happens. But if that doesn't work out, then we might have to think about these causes too.
Absolutely beautiful. Does that make sense to everyone? Very challenging topic, but love the base rate of disease and trying to explain everything through this Lasix. And here's where it gets a bit tricky, is that oh yes, we did give the patient fluid. The first day we gave 500 cc's. We didn't want to give too much fluid because we just didn't know how well his kidneys would handle that. After 500 cc's, nothing changed. Like his creatinine stayed at 2, his BUN stayed at like 95. Then we gave him a liter of fluid per the nephrology service. We saw the creatinine go from like 2 to 1.96 and the BUN to go from 95 to 80. So some result, you know, especially if the creatinine is not an accurate measure of this patient's eGFR, and we're starting to see the BUN come down, it's telling us that there was some degree of pre-renal azotemia. But here's where it gets a bit more challenging, is that the pembrolizumab was started 2 months prior to this hospitalization, And it was really in the past 2 months when we started seeing the change in creatinine. And so I think this allows you to sort of, I guess, like two things. I want to make one comment and then pass the mic to Robbie to just take us through his approach to or ask the audience for intrarenal AKI, like how you think of that. But I want to highlight this law of proportionality. If, in medicine, we often say, is it this or is it that? But oftentimes it's multiple mechanisms contributing to your patient's problem. It's just that each mechanism is contributing at a different level. This is the law of proportionality. So how do we apply that to this case? If everything was due to Lasix that he was on for years and had no issues, then with fluid, we should be able to reverse this unless he has like concomitant ATN from like a, permanent hypovolemic state. But it's really important to just consider this law of proportionality so you don't prematurely close the case and you don't consider another possible etiology for kidney injury, which I think is at play here. But yeah, I'll pass the mic to Robbie. Now let's share with you like what I think needs to happen next.
Yeah, no, I completely agree with you. I think that like when somebody has a persistent rise in kidney function, it's almost always intrarenal, rarely postrenal. Just the fact that it's not getting better, it's slowly worsening. And I think we break that down into, is there something wrong with the glomerulus, the tubules, the interstitium, or the vasculature? And by far and away, the most common cause of slowly progressive kidney dysfunction in a patient without diabetes. In diabetes, it becomes glomerular. Without diabetes, it's tubular interstitial disease by far. And it's either recurrent ATN from kidney dysfunction or it's things like medications like PPIs and toxins and all sorts of stuff like that. So here, I think you have a very powerful culprit in pembrolizumab to think about. So I don't know how people would tackle this because the pembrolizumab is key for this patient for their cancer. But if you accumulate enough tubular interstitial clues, which is any electrolyte perturbance, so hypokalemia, renal tubular acidosis, or you see pyuria, or you see white blood cell casts, all those are pretty powerful. And so some of these patients end up getting a kidney biopsy to look for tubular interstitial disease, which may be on the plate for this patient. The issue maybe in this situation is that the kidney dysfunction has been going on for at least a month. And so the yield of the biopsy declines with time because the characteristic clues of inflammation get replaced by fibrosis. So it's a tricky decision with these patients when they've had tubular interstitial disease for a while, whether to not biopsy or not, or just to empirically stop the medication and see what happens. But it's a complicated space to be in.
That's such a stellar point that like chronic inflammation for a prolonged period leads to fibrosis in any tissue or organ and may alter the yield of your diagnosis. Very bright. I think that in this patient, you continue to hold the Lasix, you continue to track the creatinine. I think the difficult part, which I don't know the answer to, is that he is receiving benefits from this pembrolizumab. But when do you question the risks of that medication? Because if you hold that medication, then you're not treating his underlying cancer. But if you give that medication and you're adding fuel to a fire that you're not sure exists, then you're worsening the kidney function. I don't know what it's like. This is a very complex decision making. I think you got to talk to the nephrologist and the oncologist to get their pretest probability for this being the cause of interstitial nephritis. And then you got to also talk to the oncologist and say, what is the benefit from the pembrolizumab? It's only through understanding those two that you can actually make an educated recommendation to the patient. Personally, I think we really have to keep giving fluid until his BUN stops improving, because it could all, in theory, be just a pre-renal hypovolemic state, right? And the Lasix could explain the hypokalemia, the worsened metabolic alkalosis, the worsened rise in creatinine. But then you have to ask the question, why now is Lasix causing causing all this havoc? Like, why wasn't it before? And is anything changing what the patient is consuming? Is, for example, their heart failure just improving? Like his was HFpEF, like has he had, I don't know, an improvement and no longer actually needs the Lasix? But I'm really interested to hear the thought of all of you on this topic. So Hans, can you tell me or tell us, what are your thoughts there? So yeah, please share with us.
If the hypothesis with pembrolizumab is correct, we can just give him some steroids that'll stop the treatment. And when he improves, we can at a later time resume the same treatment again. That would be okay. It's normally done in oncology like this.
Wow, I love that. That's awesome. Because I actually asked the nephrologist if we should start prednisone, but I didn't think about just treating the fire that the immunotherapy is creating with a small dose of prednisone 40 or 60 and reducing the flare so the patient can benefit from the pembrolizumab. Thank you, Hans.
Stunned silence, Prof. Rez. I think it just goes to show you how management reasoning is so much more complicated than diagnostic reasoning. Diagnostic reasoning, there's like, get a CT, get to do a heart cath, get an MRI, but like how you actually real life is so much more complicated than that. My answer is, gosh, I have no idea what to do. If I were by myself, what would I do? I think that these kind of cases, I honestly would probably just lean in with the patient and be like, this is what I'm worried about. And I wouldn't be surprised if the patient's like, oh my gosh, no, I don't care about my kidneys. I want this cancer gone and I'll go on dialysis. I don't care. I also wouldn't be surprised if the patient says, my kidneys are really important to me. My mom died from dialysis related issues. Please stop it. And we can figure out something else for the cancer. So I feel like whenever you're in this kind of very tricky space, you're trying to find the perfect answer. But I think the patient may have very important preferences that when you're trying to like find the difference between this little thing with this little, like which one is better, maybe the patient has a big preference and that can guide you. If not, good luck. I have no idea what to do.
I love that. I'm going to share, not yet, Jane, we didn't, but I'm going to share what my attestation looked like.
Whoa.
And oh, actually, I can't post it in here. Never mind. I thought I could post it in here. But I will keep all of you updated. And I think that it was such a fun case to think about. It really was, like the electrolyte abnormalities. And just knowing that usually at time point 0, you can't have an answer with AKI. You can't. It's really on the subsequent day after your test of your treatment of choice that you get an answer, whether it's hypovolemia, volume overload, etc. The other thing I did send, his anion gap was 4. And I told you, Robbie, I would never go down on missing myeloma ever again in my life. So I actually did send a paraprotein panel because I saw that low anion gap. And then I was like, could paraproteinemia cause like an RTA leading to hypokalemia? But that wouldn't explain the alkalosis for sure. So we sent that as well. But at the end of the day, if you're honestly asking me what I think is, I think it's Lasix, but I am concerned for interstitial nephritis, like concerned enough that I do want a biopsy, to be honest. Why? Because we don't even know why the patient has CKD. No one has told us why this patient has CKD. And you shouldn't assume that it's diabetes, even if someone has diabetes, because 30% of the time you'll be wrong. It's not, it's something else. So in any case, personally, I would talk to the patient. I think a renal biopsy it's pretty safe. It's pretty safe, unless the patient's on an anticoagulant or aspirin or something like that, or they're hypertensive. He's normotensive. He's not on any blood thinners. And I think, it's important to understand what's causing this so he doesn't have to cross that bridge of, do I want dialysis or not to stay alive longer? That's coming to you from Los Angeles, your big, bald, bad brother.
Yes, his name is
Oh. David, I think the BUN creatinine, honestly, my impression is that he's lost muscle mass. And therefore his creatinine is just not a good estimate of his GFR. We did send a cystatin C, and I promise to update you, David, on the cystatin C. If it's not, if it doesn't show worsened kidney function, then we go back to Han's theory of some kind of protein load that we haven't yet identified as a team. Exhausted muscle mass, yeah.
Amazing, y'all. A real treat to have you. Prof. Rez, thank you for that amazing, very informative case that taught us about hypokalemia, alkalosis, acidosis, lungs, brain, anion gap, myeloma. Oh my God, the things we talked about. Thank you all for nerding out. That was a real treat. I'll spare you my case that I was going to present for RLR. I think you'll really enjoy it. But yeah, thank you all. It was real.
You want to know the funny part though? So
Yeah.
I spent
Yeah,
like, literally like 45 minutes writing this attestation, like looking at all of our schemas, just like, and I'm like, oh, like someone's trying to knock on the door. And I'm like, I'm busy right now. I don't even open the door because I'm like so into it. Like I'm in a flow. I do this. And then before I even sign it, we hear from the nephrologist saying that they think everything is just hypovolemia and just get fluid. That was there. And I was like, I'm going to stay honest to what my impression was. And I still signed that note in my attestation. I am thrilled that the BUN is coming down. I hope it continues to come down. But would I be excited if it was something else? No, I wouldn't. The main thing is the patient is what matters.
100%.
Can you edit this out of the YouTube, Robbie?
No chance.
We're getting into a tricky situation right now.
No chance. If I'm a coder to get billing from Prof. Rez's notes, oh my gosh, you probably can code so hard. Myeloma and
Not at all. If you were a biller, you'd be like, what do you mean by AKI? And is it recent onset or not? Like literally, like I had nothing in my attestation is codable.
I think that's the gold standard, honestly. All right, y'all enjoy the rest of your Friday. Thank you.
Thank you all so much.